anesthesia, it is critical care, acute and chronic pain, as well as cardiac anesthesia. So she's a very person who's very well versed with pediatric anesthesia. She's going to be talking about a very important topic, and that is IV fluid in pediatrics. So over to you, Dr. Aileen.
Hello, everybody. I bring you warm greetings from the Department of Pediatric Anesthesia, St. GS Medical College and King Edward Memorial Hospital, Mumbai, and where we run the DN Pediatric Anesthesia course. And at the outset, I would like to thank Dr. M.D. Kaur for this opportunity to speak on my topic. So when Madam asked me to speak on this, I thought a discussion on perioperative fluids, and the first thing that I said was not again. But why are we here still? So recent literature is challenging old concepts regarding maintenance fluids described by Holliday and Segard. The volume and the content of perioperative solutions is being revisited. We're also looking at revisiting the need for pre and post-operative fasting, and we're looking at methods to better assess volume status. So what I'm going to do over the next 20 minutes or so, I'm going to discuss a few case scenarios and we'll see how to manage fluids in those children. So the first case is a 3-year-old child who is posted for an open herniatomy. The expected surgical time is 45 minutes. He had breakfast 6 hours back, clear juice 2 hours back. What and how much fluid will you administer? So first, let us see, why do we give perioperative fluid in the first place? So we want to maintain or re-establish the normal physiological state, which includes the extracellular fluid volume, the blood volume. You want to maintain tissue perfusion, metabolic function, and you want to maintain or correct any acid base and electrolyte status if it was already there preoperatively. So we're all familiar with this preoperative fasting recommendations. We all know the 642 rule. So we know that different foods empty differently. The emptying time is different. For solids or fatty foods, it is 8 hours. For infant formula, it is 6 hours. For breast milk, it is 4 hours. And for clear fluids, it is 2 hours. Now, this was a paper which was published in Pediatric Anesthesia, where the authors actually, they just studied fasting times in children who were posted for elective outpatient procedures like short dental procedures, where the practitioners were aware of the 642 rule. And in spite of that, they found that the fasting times were as high as 12 to 14 hours for liquids, and on an average around 7 to 8 hours. So what are the problems with this? This can cause hypoglycemia, ketoacidosis, hypotension on induction of anesthesia, and it decreases the satisfaction of the parents and the overall anesthetic experience of the child. So again, these are two landmark papers which were recently studied. In the first paper, they saw that they actually studied the incidence of pulmonary aspiration in children. So we started off with Mendelssohn's paper, where we were so worried and paranoid about aspiration, but we now know that it is not such a big problem, especially in children. And in the first paper, when children were allowed, where fasting times were kept actually very short, they found that there was an improved perioperative experience for both the child and the parent. And in the second paper, they studied, the gastric emptying times when 1 hour of clear fluids was given compared to when 2 hours was given. And they found that there is not much difference between these two. So therefore, we came up now with consensus recommendations. So mind you, these are consensus recommendations. It's still not a guideline. It will take a while for it to become a guideline. So these are endorsed by the AAGBI, that is the Association of Anesthesiologists of Great Britain and Ireland, and also the French and the European Societies of Pediatric Anesthesia. So now we say that preoperative fasting times should be as short as possible. Fluid therapy may not be necessary in children who undergo short procedures at all. So now we know that for solid foods or for formula milk, this is not changed. It is still 6 hours. For breast milk also, it is 4 hours. There's no change in this. But when you look at clear fluids from 2 hours, the consensus is now come down to 1 hour, and you can give 1 hour of clear fluids just prior to your procedure. And in fact, we know now that that clear fluids take as short as 30 minutes to empty the gastric emptying time. And if you give a carbohydrate rich fluid, this gastric emptying time is even shorter. So for this first case of ours, this child who did not have much of fasting, and for a short procedure. Now, what is a short procedure by definition? It is a procedure lasting for less than an hour, and there is not, it's a non-bleeding procedure. So for these procedures, your child need not be given any IV fluids at all. Now let us look at this next case. This is an 8-year-old child of weighing 8 kgs with intestinal obstruction. He was fasting for 10 hours. There is history of vomiting, and you can see there is gross abdominal distension. The patient is posted for an urgent laparotomy. So now this is clearly a child who has had excessive losses and who is going to need replacement. How do we manage this? So we usually correct the deficit. We have to give a maintenance fluid as well, and we have to replace whatever other losses. So how do we correct this deficit, and what is this? So this is the fluid and electrolyte losses that occurs prior to surgery. This could be due to the starvation process, or it could be due to the disease process itself. Like in this child, there is diarrhea, vomiting. You could have a child with burns. You could have a child who is hypothermic, and you have to replace those losses. Or you could have a child like certain surgical conditions like gastroschisis, where the preoperative losses are huge and very variable. So this deficit therapy has to be estimated. You estimate the severity, then you determine what is the type of deficit, and finally you repair the deficit. So when we look at estimation, we're all familiar with this table. It's in all of our textbooks. We can divide it into mild, moderate, and severe, and we look at all these clinical signs to grade the level of dehydration. So you can go by the pulse, you can go by the skin turgor, urine output, your capillary refill. These are all very, very good estimators. But a word of caution here, if you go by systolic PP, if you look here, it will be low or unrecordable when you reach severe dehydration. That means if you actually go by BP, you will pick it up very late, and by then you've already missed the bus. Another tip here in this table is, if you know the preoperative weight of the child, for example, if it was 10 kgs, and now if the child is weighing 8 kgs, so you already know that there is a 20% weight loss here, which automatically brings the child into the severe category. So you know now that you have to replace around 200 ml per kg, since it is 20% of a weight loss. So that can help you with easy calculations. Now, how do we correct this deficit? So there is a rapid phase, which is the phase 1. So here and there is a slow phase. So in the rapid phase, you correct it with an isotonic solution. You can use either Ringer's lactate or isotonic saline. Now you give a bolus of 20 ml per kg over 20 minutes. You can give up to 2 boluses. If further boluses are needed, then you should switch over to blood or colloids. Now, the phase 2 correction is corrected more slowly, and this is usually done by pediatricians or the pediatric surgeons in the ward itself. And it's done over a couple of days. So here, depending on the labs, you can use any of these solutions. Now, we come to the maintenance fluid calculation. And this was given by the two pediatricians, Holliday and Segar, way back in 1957, and it stood the test of time. For so many years this has been used. So they actually calculated the water and electrolyte requirements, and they said that it parallels caloric expenditure, and at rest the fluid and caloric consumption are equal. Now Holliday and Segar, what did they do was they calculated these requirements for children who were in resting conditions in the ward, and they were used for maintenance. They never took into account intraoperative calculations, where the losses are dynamic and where there can be huge losses. On the other hand, they never specified what type of fluid should be given. So this is the Holliday-Segar rule, which we all know, the 4-to-1 rule, where they said for the first 10 kgs of body weight, you need around 100 ml per kg per day. For the subsequent 10 kgs, you need 50 ml per kg. And after that, you need 20 ml per kg. But we know that we need to calculate it per hour. So we came up with 4, 2, and 1. Now, at the a little later, Furman's calculation came, and this is what we use. So we calculate the maintenance requirement. We multiply it by the hours of starvation, and 50% is replaced in the first hour, 25% in the second hour, 25% in the third hour, and this deficit is corrected with isotonic fluid. So Berry was another person, and who came up with his formula in 1986, and he said that in children less than 3 years, you give 25 ml per kg. In more than 3 years, you give 15 ml per kg of a balanced salt solution in the first hour of surgery. So he was the first person to come up with the concept of giving a balanced salt solution. And all these formulas were actually, based on the premise that children were fasting for at least 8 hours preoperatively. That is why so much of fluid was given. Now, what are the limitations of 4:1? Like I said, intraoperatively does not account for the deficits, the third space losses, and the unusual metabolic demands because it was meant for resting patients in the ward. And postoperatively, there is an EDH response to surgery, and this starts as early as 6 hours. It peaks in 12 hours. So, this will lead to further fluid retention and hyponatremia, and Holiday and Segar did not take this into account. So, this can lead to fluid retention if you use the same 4:1 rule. So, before I move further, I would like to move into a little bit of history to see what fluids were given and how we have come up with what we are using now. So we'll start off with, let's look at plasma, the composition. So you can see that it has sodium, there is potassium, calcium, magnesium, and among the anions, there is chloride, there is bicarbonate, there is lactate, and you can see the osmolarity here, the osmolality, it is 288. Now, if we look at sodium chloride, this was the first solution that it began to be used during the cholera epidemic. So here there is a lot of sodium, you can see 154, and there is a lot of chloride. So the in vivo osmolality is 288. Now there is a slight difference between in vivo and theoretical osmolality. So in vivo is how the solution behaves in the body. Now because the anions, they get absorbed onto plasma proteins. So therefore, the effective or the in vivo osmolality may be slightly lower than the theoretical osmolality. So you can see here it also has a negative base excess, -24. Now the problem with this was that it can cause, it was good for hyponatremic dehydration, but it can cause hyperchloremic metabolic acidosis when given in huge amounts. So later on, Sidney Ringer, the physiologist, he came up with Ringer's solution. And this has sodium, which is almost the same as that of plasma. Potassium, again, same as plasma. It has a bit of calcium. There is chloride. And the in vivo osmolality, you can see, is same as that of plasma with a negative base excess. Then we came up with Ringer's lactate. So this is the same as Hartmann's solution. Here you have sodium, which is slightly less than that of plasma. You have potassium. You have calcium, magnesium, there is chloride, which is lesser than that, or almost the same. And then you have lactate. So here lactate is used as a precursor of bicarbonate. So, you cannot actually add bicarbonate in these solutions because it's an unstable anion. So you need to give precursors. So in RL, lactate is the precursor and that is converted to bicarbonate by the liver. So the in vivo osmolality, if you look of Ringer's lactate, it is slightly hypotonic compared to plasma, but it has a positive base excess. And then we came up with the balanced salt solutions. So these are solutions like Plasmalite, which is a trade name, but they are basically all the same. So this has sodium, potassium, it has calcium, a bit of magnesium, and among the anions, there is chloride, acetate, malate. So here, what is important is that acetate is given as a precursor of bicarb. So that is more physiological. It does not require liver for conversion. So, the conversion of acetate to bicarb is faster in these solutions. And here, the in vivo osmolality, as you can see, is almost same as that of plasma and it has a potential positive base excess. Then we look at the solutions which are used for intraoperative maintenance in children. Now, here again, we look at this is the hypotonic electrolyte solution with glucose 5% dextrose, and this is your the solution which is commonly your isolate P, which is commonly used in pediatric patients in the ward in resting conditions. So here you can see it's a hypotonic solution. Sodium concentration is very low, potassium is low, there is calcium, a bit of magnesium, it has chloride again, this is very less, but it has a lot of glucose. Now, this was added in such high quantities because, again, you have to replace glucose stores in these children in resting conditions. And the in vivo osmolality, you can see it is very hypotonic. Then we have the Ringer's lactate with 1% glucose. So here the sodium you have it's same, everything is same as that of Ringer's lactate, except that you have some amount of glucose here. And then you have the 1% electrolyte solution in you have the balanced salt solution, that is plasmalite with 1% dextrose. So again, the composition is same as plasmalite. It has acetates over here, except that there is some glucose present and it has a positive base excess. So all these tables I have actually taken from Supplement. These are the German guidelines which were published in 2017, and this is the landmark paper which has actually changed practice. And I urge all of you to go back and to read up this paper. And this is what we are actually using now in practice. So finally, which type of isotonic fluid should you choose? So normal saline, it is isotonic. It avoids the risk of hyponatremia. However, the problem is the high chloride content, which can actually suppress your renal blood flow. So it does not have a bicarbonate precursor and it can cause hyperchloremic acidosis. Then we have RL. You can safely use this, although it is slightly hypotonic, but it can be a confounder for lactic acidosis if you are having to give huge amounts of Ringer's lactate, for major surgeries, and you cannot differentiate whether there is decreased perfusion or whether there is hypotension and what is the cause of your lactic acidosis. Acetate containing balanced electrolyte solutions like plasmalite are the best because the metabolism of acetate is faster, it is independent of hepatic function, and these will not interfere with lactate estimation. So when you have to give huge amounts of fluid, these are the best solutions to use. So for this child, what we used to do previously to calculate how much fluid you would need to give intraoperatively, we calculate the fasting deficit. We use 4-to-1 rule, and we get she is fasting for 10 hours, so we get the deficit as 320 ml. In the first hour we give half of this, then the maintenance will be 32 ml per hour, and the replacement, say for the losses for an exploratory laparoscopy, we take it around 10 ml per kg. So if you calculate all of this in the first hour, we would have got a replacement of 272 ml. So the problem is, if you use this method, you actually have to sit and do all these calculations. And now this is again from Supplement, our landmark paper. So this article says that you need not do all this now. You need not sit and do all these calculations. You can just use your rule of tens, which is the simple rule where you give a background infusion of a balanced salt solution with some glucose. So this can be 1% or 2% dextrose, and you give it at a rate of 10 ml per kg per hour. Now, if you need fluid therapy over and above this, then you add a second fluid, which is going to be only a balanced salt solution without dextrose, and that you give it at a rate of 20 to 20 ml per kg. And you vary this rate depending on the need. Then if you need volume therapy over and above this, you can move on to albumin or your colloids at 5 to 10 ml per kg. And if you need blood to be replaced at any time point, you replace it with blood 10 ml per kg. So now we move on to neonates. And can you use the same thing for neonates? So neonates are different compared to adults, aren't they? Now, if we look here, the body water composition is 80% of total body water compared to of total body weight. If you compare it to adults, like ours is 60%. And out of this, if you see, almost half of this is in the extracellular fluid. And if you look at the plasma composition, it is almost the same across all age groups. Again, over here, the interstitial fluid composition is the one that is higher compared to adults, and this is this is the reason why all this comes into the circulation during the first a week of life, and that is given off as the postnatal diuresis, and that is why neonates lose around 10% of their body weight over the first 10 days of life, because all of this is given off as the postnatal diuresis. So if you see, the plasma composition is the same across all these age groups, which means that we can use the same fluid composition that we use for adults, even in neonates. So this is the maintenance fluid requirement in neonates. Now, on the first day, you can remember that we give 60 ml per kg per day. Second day, 80 ml per kg per day. And from the third day onwards, up to the first month of life, you can give 100 ml per kg per day. Now, just remember 60, 80, 100. Now, why we give less on the first 2 days? This is because we are waiting for the postnatal diuresis, which will set in from the third day onwards. And after that, you can safely give a higher amount of fluid. Now, what type of fluid? You give 10% dextrose. This is because of the glycogen stores to replenish that. And from the third day onwards, after the diuresis, you can add your 1/4 saline. So 5% dextrose plus 1/4 saline. So this is actually present in isolate P. If you look at the composition of isolate P, and that is the solution. So iso P per se has gone out of practice completely, but it is still given in the neonatal age group. So they are given this solution. The sodium and the potassium requirements are 2 to 3 milliequivalents per kg per day, which is present in isolate P in the same composition. Glucose requirement is this much again, which is present as 5% dextrose in this solution. Calcium is started from day 1 of life itself, and it is added to the solution. So let us see, for a short surgery like a hernia, we would give RL with 2% dextrose at maintenance rates. And if you have a major surgery, so you can, the neonates are usually shifted with their infusion, the maintenance infusion that is going on in the ward. So you can continue that infusion at the maintenance rates, and you add an isotonic glucose-free solution over and above that in a separate burette set or in a separate infusion pump. And here the infusion rates are very variable depending on the type of surgery. So right up to 6 to 50 ml per kg per hour, depending on what is the surgery. So always remember a word of caution in neonates. You do not want to err in giving them, lower amounts, but you do not want to overload them as well, because they can go into pulmonary edema. So you always have to use an infusion pump, or if you don't have this, at least use a burette set for administration. So now we move on to the third case, which is a 1-year-old 10 kg child who was having a Wilms tumor, who was posted for a bilateral nephron sparing surgery. So here our concerns are the major hemorrhage. Intraoperatively, there is going to be renal clamping. You need to preserve renal function, and we needed to accurately monitor and optimize intravascular volume. So what we did, we used plasma light here at 10 ml per kg per hour. So we did not want to use ringer's lactate because, there would be renal clamping and there would be hypoperfusion. So also there could be hypotension. So you do not want a confounder to differentiate, is it because of, is the acidosis, lactic acidosis because of hypotension? Is it because of inadequate perfusion because of the clamping? Or is it because of your ringer's lactate that you're giving in huge amounts? So in these situations, plasma light is best, and we use that. The blood loss was 600 ml, which we replaced with 250 ml of packed cells and 130 ml of FFP. Now, urine output was maintained at 1 ml per kg per hour. But the problem is that there were some times in the surgery when, the urine output was dropping, and we did not actually know, whether what was going wrong. Were we giving enough, or, is it because of the clamping or what? So how do you monitor perioperative fluids intraoperatively? Now you're giving fluids, but how do you know whether what you're giving is sufficient or not? So simple things like inquiring about preoperative fasting times. We do this in all surgeries. Clinical examination, you can look at your capillary refill time, your skin turgor fontanelles. Now all these can be done preoperatively, but intraoperatively it's actually very difficult to do. So for your minor procedures, you can do basic monitoring. And if you have any doubt, you can just get a blood gas to check. For major procedures, we put in arterial lines or central venous catheters, like we put in this Wilms case. And you monitor trends in your, central venous oxygen saturation. In our case, we monitor trends in base excess and in lactates. Now, there are other methods to assess fluid responsiveness. So we know that our cardiac output depends on the preload, the contractility, and the afterload. So if we can assess our preload, we can actually assess fluid responsiveness. Now, in adults, we know that positioning or passive leg raising is a very good test, but in children, it's not suitable. And that is because the lower limb mass is very less. So, it's going to cause very little venous return back into the heart and not going to be able to make out anything. On the other hand, external pressure on the liver can be used. And if you have an invasive blood pressure, or you can actually look at the tracing, and you will see an increase, and that means that the patient is fluid responsive and you can give fluids. Then you have those parameters which are based on the arterial pressure waveform. So you have your systolic pressure variation, stroke volume variation, pulse pressure variation. You can use all of these. But the problem is that these are very well validated in adults, but in children, especially those less than 5 years of age, they are not well validated. And that is because of the caliber of the arteries and the resistance and the compliance of these pediatric arteries, which makes these very, very variable in children. So better than that and very attractive in the pediatric age group are those based on your pulse oximeter or the plethysmographic tracing. So that is your perfusion index or your pleth variability index. And you know that if these values are very high, you can just look at your plethysmographic tracing. And if there is a lot of variability, or if the values are high, and if you give fluids and if the values come down, then you know that the patient is fluid responsive. The best, however, are echocardiographic parameters. So here you measure your stroke volume. The best is you measure your aortic blood flow velocity across the aortic root, or you can see for your IVC filling. Now, all these will be best if you have a trans-esophageal echo. But if you do not have it, you can even use a transthoracic echo, but you will have to probably wait for post-operatively, or you can do it pre-operatively and then post-op, and then, you can get some idea. So this is the IVC filling that we commonly do. Here, you need to look at, it's a subcostal view, and you need to get the IVC opening into the RA. So it's important to get this, because otherwise you can, you may mistake it for the descending thoracic aorta. So after you get this, you put it in M mode, and then you look at the collapsibility or the distensibility in a patient who's spontaneously breathing. So here you can see this is a relatively full IVC, and if you contrast it over here with this one on M mode, you can see here it is collapsing. Okay, so this is a collapsible IVC, and you actually take measurements of the maximum minus minimum upon maximum, and you actually get your percentages. And if it is more than 60%, it means that the patient is fluid responsive and you should give a fluid challenge. So now we'll move on to our last case. This is a 4-year-old who has undergone circumcision under GA with a penile block. Surgery was uneventful. 30 minutes after shifting to the PACU, the child is wide awake and he is inconsolable. So what has gone wrong here, and what is the problem here? So now we know that this could be due to pain, it could be due to emergence delirium, or it could be simply that the child is just thirsty. So this was a study published recently in BJA, where there were 2 groups, and the authors actually, they gave children in one age group a more more liberal fluids. So as soon as the patients were, they were in the, brought to the recovery and they were conscious, they gave them 10 ml per kg of apple juice. And in the other, that was the liberal group. And in the other group, the routine group, they did not give them any fluids until they were shifted back into the ward. So they found that the incidence, that those children who were, in the control group, the incidence of post-operative nausea and vomiting was more, because those children were given more of opioids also, and because they were more, crying excessively. But actually the cause of this crying was not pain, it was simple thirst. And therefore now we advocate that post-operatively early oral feeding is safe and well tolerated. Early on-demand oral feeding can be started post-operatively even before the return of bowel function in healthy patients. However, introduction of solid foods should be done more cautiously. So this was the editorial in pediatric anesthesia in the late 1990s, where children were posted even for routine surgeries like tonsillectomies, started throwing convulsions post-operatively, and that was because of hyponatremic encephalopathy. So we know now that there is an ADH release which starts during surgery itself, and it peaks 12 hours. So all of this is because of ADH release, and this administration of hyponatremic fluids is again can worsen all of this. So therefore, the recommendation for post-op fluids now is you restrict post-op IV fluids by 33 to 50%, and here post-operatively, now we move on to the 2-1.5 rule for the first 12 hours. After 12 hours, if the child is able to take orally, then well and good, you give him orally whatever he can take. The problem comes if the child is unable to take orally. So now here, you need to give your standard maintenance rate. You move back to your 4-1 rule after 12 hours, but you give 5% dextrose with half strength normal saline. And here you need to repeat sodium, glucose, and do your fluid balance calculations. So now the proposal for perioperative fluid management is, and this is just to recap whatever I've spoken about till now. Preoperatively, you keep fasting times short. So clear fluids up to 2 hours preoperatively. So, for minor procedures, that is short, non-bleeding procedures lasting less than an hour, you need not give anything at all if the child has just taken fluids, 1 hour prior, or you can give a background infusion of a balanced salt solution with 1 to 2% dextrose at 10 ml per kg per hour. For intermediate procedures, you can adjust this background infusion to the actual requirements. In addition, if you need more, then you start a second solution of only balanced salt without glucose at 10 ml per kg. If you need anything over and above that, you can start a colloid. For major procedures, you use the same as your intermediate procedures. If you need blood, you start blood at 10 ml per kg. And post-operatively now, we allow children to eat and drink soon after the procedure. So that's it from me. Thank you very much. And if there are any questions, I will be happy to take.
Thank you, Dr. Raylene, for a very clear, crystal clear, and a beautiful lecture.
Thank you so much, madam.
Very well done, yeah. And I like the fact that you took case scenarios, and based on that, you actually give the practical, answers to a particular case. I don't know whether there are any questions in the chat box. Are there any?
No, ma'am.
Okay, so anyway, I think very well done. And also covered everything. I mean, just a few practical tips to summarize is that a few basic things that you should always know is that children of all ages tolerate fluid excess and deficit equally badly. So meticulous fluid requirement is very important. The smaller the child, the more acute is this response. So you have to be very careful, especially neonates, and try to use infusion pumps like you rightly said. And other things is that there are various fluid regimens which you have rightly said. And I like the fact that first we used to give excess of glucose, then we stop them, and it's a good idea. I think most hospitals, I don't know, ours we should have 1%, 2% glucose. And more important than that, just to follow, and I think institutions should develop their own protocols. And you rightly pointed out, which I was also going to say, that actual practical fasting in children, this is for the residents, is really much more than what you theoretically write. Everybody's given feeds at the same time, and then their surgery may come at 2 o'clock in the afternoon. So it is also important to monitor blood glucose, especially for the neonates and the smaller children. And so another thing about a practical, of course, for small procedures, IV fluids are not required, but I think a lot of factors you should factor in, especially the pre-op fasting. And the best is to ask him when and what did he take, so that is also very important. And the end, I would just like to say one thing, that whatever fluids you give, they should be always warmed, especially important in Delhi and North India, where there are such severe winters, because that becomes a very important cause for, non-reversal of small children. And monitoring, as you rightly said, is very important. If you don't have all those complicated monitors, which are ideal for major surgeries, but at least simple monitoring devices can be used for regular, and start monitoring pre-op only. Don't know, how much fluids the pediatric surgeons have actually given. And I think it's if a good pediatric surgery department is there, they really continue the IV fluids till the time of surgery. So that is also something which should factor in. But other than that, I think Dr. Raylene, you did a very, very good job.
Thank you, madam.
Thank you so much. So from here, we now we move on to the next lecture. And my second speaker today is somebody that I know very well because she's from my institution, Dr. Charu Bamba, who's a professor in anesthesia at Savijay and BMMC, and has been an exclusive neonatal emergency anesthetist for the past many years. She chose it and she's there. So there can be nobody better than her to talk about neonatal emergencies. Her areas of interest, as she has mentioned, is neonatal anesthesia